So this is live now.
Right.
So if you want to take it.
Mm-hmm.
Okay.
So once you get all hooked up and ready to talk, then
So okay.
so yeah, it's just like I was saying, only the audio that was sent in the episode was recorded, so if at the end people ask you questions, it's going to be yeah.
So do you want people to meet with her after lunch, or you're going to take her for lunch? Or?
Any of the above. Yeah, so if you wanted to continue with her, that's what I was saying, that'd be fine.
Okay.
What should do that?
I don't know. I think we talked about a lot of stuff. But, so what time is Fellows Conference?
3:15.
Okay. And then you were just going to take her to lunch? There was nobody else? Okay. All right.
Yeah, Sarah Michael might want to meet with her also
Yeah, I
in that.
think Sarah should.
Mm-hmm.
Yeah.
Or the two of you can go out with her to lunch afterwards, whatever you like.
Yeah.
It's completely open. It's just kind of a freewheeling day.
I'll talk to Sarah and see if she's available. She's not. I can talk to her some more. And I'll just call her the lab and change some stuff around.
Okay. Yeah, that'd be great. Yeah.
I'll just. Okay. What's that? Very last section.
I'm going to read your letter.
Oh. Oh, I get to hear what it's like.
Yeah.
Oh, by the way, thank
I
you.
wrong
So I
place,
went.
too.
So I went to the one in Chicago just recently that happened. So it was good. It's a nice environment. We have just good diversity in thought. You know, yeah, it's just intellectually a lot more stimulating. Yeah.
And in the future, there will be. We're used to being able to go back.
Yeah. Oh, what did we vote on? We voted to go to Colorado in 2 years. So where is it next year? There's already somewhere next year. Oh, California.
They usually pick. Oh, Monterey. It's in Monterey. Oh, that'd be great. That'd be a
Yeah,
lot of fun.
and then Colorado.
Yeah. More people will wander in. So, but I think for the sake of, let's give them a couple more minutes, but I think for the sake of not squeezing the talk too much. Hi. I guess that is. Danny was just signaling me. Why don't we go ahead and get started? I know more people are going to wander in. I wanted to introduce our Grand Round speaker today. This is Dr. Camilia Martin. She comes to us from Harvard, and she's a neonatologist at Beth Israel Hospital. She's actually in town to, boy, we're working you hard, to give 2 talks at our National Neonatal Nutrition Conference that's taking place. All this takes place just before the marathon weekend. And, that's something you might want to check out. There's some very interesting speakers that come there, strictly related to neonatal nutrition. So I met Cami actually relatively recently, although I followed her work for about 5 years, on a trip that we made to Indonesia to talk about neonatal nutrition and gastroenterology. And we had a great time. And in particular, I was struck by, here is somebody who was tackling fats. So if you know the neonatal nutrition world, it's all been about protein, 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 and protein. And we realize we don't have any idea what we're doing with fats. Moreover, she has a very interesting research program in not only the nutritional benefits of fat, but some of the immunologic and neurodevelopmental effects as well. She runs a lab that, not unlike several of us around here, goes from basic science, mouse models, piglet models, through large-scale human studies. She has her master's from it was the Division of Epidemiology, as I recall, at Harvard. She trained at Cornell, at Northwestern, and she's been at Harvard first as an instructor and now as an assistant professor since 2000. And we are just really, really pleased to have you here. You're going to talk about something which I can barely pronounce, which is the pleiotropic effects of fatty acids in critically ill infants. So please welcome Camilia Martin.
Okay, thank you very much. I'm very happy to be here. And yes, I'm going to be talking about what I've learned over the past 4 years and the many different functions that fatty acids can play in neonatal health. But one thing I wanted to also discuss, and as preparing the talk, is how do we broaden that scope a little bit? Because I know there's non-neonatologists in the crowd, and I think a lot of what I have to say may have some relevance to other disease processes and other populations as well. So this is my disclosure. Consultants for various nutritional companies, research support from foundations and industry, and on the Scientific Advisory Board of Alcresta. You heard my background, but really this is to make one point, in that initially I did get my master's in epidemiology, love epidemiology and the data sets and looking and analyzing large data and figuring out associations. But at some point, and always within nutrition and growth and neonatology, but at some point realize, what am I going to do, though, that's different at the bedside so I can change these associations I keep describing? So about 4 years ago, Harvard provided me a faculty fellowship award to allow me to transition to a translational research setting. It's been a fantastic run. And the lab I initially joined there on the right, the PI of the lab said, well, what do you see in the NICU? I said, we see lung disease, O2 dependency. We call that chronic lung disease. We see intestinal problems, a spectrum of them, culminating in necrotizing enterocolitis, and they're at risk for infections. He said, that actually sounds a lot of what I've been studying in cystic fibrosis. I know your patients don't have cystic fibrosis, but he studies a lot of nutrition and fatty acids and its effect on that vulnerable population. And so, maybe some of the mechanisms are similar. And that started, maybe coming to the realization a little bit later, but for the young folks here, is that started my pathway to realize that multidisciplinary collaborations, mechanisms of disease, speaking outside and getting to know other fields is actually very helpful for your own questions. And you may see a lot of application in how to advance your research questions and sort of broadening your network and being able to do so effectively. So over the course of the talk, I'd like to, with you, kind of discuss the multiple biological effects of fatty acids, distinguish the function of fatty acids in normal development, especially, again, in neonatologists and early infancy, but also in response to injury. And throughout discussing that, review the evidence that we have to make these links. To step back for just a few slides, because I had to relearn it as well after forgetting about it in biochemistry, is organic compounds of fatty acids. That's what lipids are, and their derivatives. They're insoluble in water, but soluble in organic solvents. Some examples: sterols, cholesterols, mono, di, and triglycerides, and phospholipids. All of this not only providing an important energy source, and as we provided in our parental nutritions, which we'll discuss, but it's important in the incorporation of cell membranes and how the cell then signals and then translates into the proteins that are important in organogenesis and regulating inflammation. Most of our source is as triglycerides and fatty acids on a glycerol backbone and 3 fatty acid tails here, S1, 2, and 3. Not enough time to go through this whole thing, but with the hydrolysis and lipolysis with pancreatic enzymes, you break those down into monoglycerides and fatty acids that are then processed and available to the cell, again, either as energy or within the cellular components to help with cell signaling and that are important in inflammation. One quick point that will become more evident why this is important later is that we have saturated and unsaturated. So saturated fatty acids are such that every carbon is maximally linked to a hydrogen, all single bonds. An unsaturated molecule has double bonds. So not every carbon has the maximal number of hydrogen and has multiple double bonds. So the nomenclature is such that you have 18 carbons. That's the first number. The number of double bonds, 3, in this example of linolenic acid. And then the N3 points to the first carbon in which it has the double bonds. The number of double bonds in unsaturated versus saturated, very important as the incorporation into cell membranes and the fluidity and the function of cells. So the diet, and specifically the type of diet that we provide to our critically ill infants, are going to be important in this process. So what are some of the biological importance of fatty acids? So I've referred several times now to the phospholipid bilayer, where these are 2 fatty acid tails, and it matters to the cell membrane and to the function of the cell what those tails are, whether they're AA, DHA, LA, another fatty acid linked to that phospholipid. This allows the cell to interact and have the proteins interact along with each other along the membrane and regulate signaling to the nucleus, which regulates the protein production. And again, much of what I'll talk about is inflammation, but also development. Here I have a picture of it being anti-inflammatory, but everything is a balance. And so I don't want to mislead you that every protein that's produced by a fatty acid is all anti-inflammatory. There may be some pro-inflammatory effects as well. So there's accruing evidence that, again, I think is translatable to multiple disciplines and age groups where fatty acids are important in lung disease, important in neurodevelopment, and also the angiogenesis of the retina, but also your risk for late-onset sepsis and intestinal disease. And examples that I'll give you in each of these realms, I think, helps point to the importance of fatty acids in regulating inflammation, organogenesis, the immune function, angiogenesis, and neurodevelopment. And so when I speak about the pleiotropic effects, that's what I'm speaking about. So I'd like to begin with what we do know about maternal and fetal acid, fatty acid delivery. I want to start here, not only because that's what I do, and a neonatologist, and think this all begins sort of right here, but also I do think it's a nice dichotomous model. Prematurity is a good model where you're balancing and understanding the importance of a factor, and you could probably attribute this sort of logic or stream of logic to other things that might be of interest to you, but it's a good model to study with an abrupt cessation of that factor. What is it doing to what otherwise should have been normal, ongoing organogenesis and development? And then you begin to tease its role in that. But then also with that abrupt cessation and a deprivation of whatever factor you're looking at, and here's some fatty acids, what does that do for the vulnerability of the host and the susceptibility to injury and how they respond to it, but also how do they repair and recover from this inflammation? Can they terminate the inflammation? So we do know in that last trimester, it is set up already to the importance of fatty acids, where there's what's called in the literature biomagnification of fatty acids from mom through the placenta with very specific transport mechanisms and to the baby. Again, teleologically thought because of the rapid increase in the development of organs, but specifically the brain. For our preterm infants, although it's concentrated in the brain, this DHA, it's also in the adipose tissue as storage. And that's important because, as you know, when our premature infants are born, they lack that last trimester, so they can build some of those adipose stores. So they don't have the resilience to then rely on themselves to maintain certain levels of fatty acids or other immunonutrients. They completely rely on our delivery and how we deliver this fatty acid. And when we do provide that at the bedside, we don't provide a lipid emulsion that actually has DHA and AA. We provide one that's predominantly LA, and I'll talk about that in a minute. So one of the first questions then, 4 years ago or so, was what do we know about fatty acid delivery? What do we know about the transfer? What do we know what happens to a preterm infant? So I collected whole blood. And this is a study that was published in 2011, looking at the fatty acid levels of preterm infants at the time of birth and over time across the first 4 weeks. And since I didn't know even what to compare it against, was able to get birth levels of 10 full-term infants. And here's an example of what we saw for the DHA. Along the y-axis here is mole percent. So that means of the entire fatty acid pool in the systemic circulation, what percent of that was DHA? And then on the x-axis is time, 0 being the birth levels. So you see for a term infant, right here, the level was about 7.5 mole percent. And for the preterm infant, 7 mole percent. So actually started relatively close to each other. Another good reason to sort of maybe keep talking to others outside your discipline, when we first were reviewing this data, Steve, who's the PI of the lab at the time, said, this is unbelievable. You can't even make yourself get to 7 to the 7.5 mole percent. He couldn't believe the levels he was seeing. He said, yeah, I can take an adult, put them on 1,000 milligrams of DHA a day, assume they're taking 100% absorption, and maybe I'll bump them from an average of about 1 mole percent to 3 mole percent. He said, so what you're seeing is something that was completely by design and purposeful. So just kind of, I think, relayed back and reinforced the importance of this probably in development. So what happened to our babies is, as you can see pretty quickly, within the first week of life, they rapidly fell. They fell to about 4 mole percent, plateauing at about 3.8 mole percent, and never really recovering from this plateau. So in levels that if you were to assume that if they were preterm, and all the way to term delivery, that they should have been exposed to fatty acid and DHA levels at this if they had remained in utero. Rather, they're being exposed to probably half of that amount. What about the other fatty acids that are often discussed? Linoleic acid also started around 7 for both groups. The preterm infant rapidly increases with linoleic acid, and then arachidonic acid showing a pattern very similar to DHA and falling from its birth levels. So an environment of fatty acid profiles that they were seeing in utero, within a week, we completely flipped it upside down. And so I'll share with you throughout the talk what I think some of the consequences we found of these changes, but also what we can extrapolate possibly with other laboratories' work about what these changes mean to an infant. So I alluded to the lipid emulsions being all linoleic acid. So it's not a surprise that it shot right up. We were giving it to them straight in their IV. So what you give is what you see. And so that was probably largely iatrogenic. We use intralipid, I think pretty much everybody in North America, which is an all soybean oil, all linoleic acid, almost 55%. So largely that. Doesn't have any DHA and AA. So why that's the case is because these lipid emulsions that we use are actually originally for adults. We just dose it down. It was also going and originally made and manufactured on the assumption that your body, when provided the essential fatty acids, should be able to convert to your distal products and convert to the DHA and AA, EPA, and other things that you need. But clearly, even despite giving so much linoleic acid, we saw the arachidonic acid came down, which is its distal metabolite. That doesn't happen in our preterm infant. Does it happen in all critically ill, whether it's pediatric or adult, is actually something we don't know. So how does our body utilize this source of fuel, but this also a fuel for other biological functions in times of critical illness? There have been a few studies to suggest that the preterm infants do have these enzymes present, but haven't been really able to study beyond that and how well they're operating. And then what about the amount of substrate that we're providing? Some data show that using autopsy data, the amount of DHA required to replicate what the baby was seeing in utero is probably about 45 mg per kilo per day. What we provide in the IV and then subsequently even as enteral feedings, breast milk or formula, is substantially less than that. So just our nutritional practices alone, we'd probably never be able to make up a deficit they see as a result of their premature delivery. So that's where they begin. And so the next question in that first half that I talked about is, what does that mean just for organogenesis? Development that they would have otherwise should be proceeding in utero and instead are now proceeding outside with minimal stores of these fatty acids. So much of the data will be on brain and a couple of slides on the retina. Here, as we all have learned that very quickly, the brain has dramatic increase in growth. Here's a curve of the cortical surface area, and then also just seeing a quick schematic here of the many synaptic connections that are made very quickly, very rapidly. Well, lipid is a big part of that. Lipids comprise about 55% of the brain, 35% of the gray matter, almost half of the white matter, and obviously almost 80% of your myelin in your myelin sheaths. So you need to have some stores to be able to fulfill these compositional needs. Here's another way to look at the data, and this is a study in Martinez, about 21 infants who unfortunately died of non-neurological causes, and he took cortical tissue and did a fatty acid profile. And what you see here is a curve of the arachidonic acid and DHA. This is gestational age. So very early on, AA is actually, arachidonic acid, a very important component of brain composition, more so maybe than DHA at the beginning. So again, just to make the point, it's not going to be just about one fatty acid. It's going to be about a balance and what you need at specific times. About 35 weeks and beyond is when you see that rapid acceleration in the DHA content in the cerebral cortex. This was a very important study to find as well, because often we can't take cerebral tissue from our babies. And so I had to think, how am I going to get a distal sort of application to what I'm looking at as a nutrient and why that may be important? And I showed you the plasma levels and the changes in those plasma levels. This study was done on non-human primates, where they looked at the relationship, the correlation between your DHA levels in the plasma and that in your brain. And there's a pretty direct correlation. It's not 100%, but it's pretty close, so that what you're measuring in the circulation may be actually also you're measuring what's in the brain. So quite humbling when we see our preterm infants dramatically fall and stay so low in deficit for so long. What is that doing to the brain? There is a couple of hints to this paper that with a preterm infant maintained on PN who had died, and then another one who had lived longer but was maintained on a high N6 to N3 diet from PN to enteral, you can see the composition of their cerebral cortex was dramatically different than the well-nourished kids who died for other reasons, and this is a DHA to AA ratio graph. So we do rapidly change it, not only in the plasma, but it is reflected in the brain as well. This is a term infant maintained on PN who didn't do so badly. So he doesn't really talk in the paper why. I think from the Haggerty data that I showed about where fatty acids are being stored, I think it's an issue of adipose tissue, and that the term infant, it just has a little bit more stores and be able to compensate for their critical illness or a deprivation from a source of fatty acids. And some other studies I haven't completed yet, the fatty acids in term babies do show a much more stable level after delivery than what we saw in the preterm infants. When I talked about saturated and unsaturated, so now let's specifically talk about not just composition, but what is the DHA doing in the brain as far as we know, or some of what we know. So this is the triglycerides, and I had mentioned about saturated fatty acids, all single bonds, very linear and straight, and the unsaturated fatty acids with the many different double bonds. The double bonds allow for branching so that when you're lined up as a lipid bilayer, you're not straight, linear, and very compact to each other. When you have that with saturated fatty acids, the fluidity and the function of the cell is compromised. With the branching that you see in the polyunsaturated fatty acids, they can't pack next to each other so closely. There's more room between them. It allows that mobility and the communication between anchoring proteins there on the cell membrane. So cell membrane and signaling, and this is one example that I thought was pertinent to what I was seeing in the lab and its potential influence in the brain. This lab looked at DHA and how DHA might help in protecting against cell death. They noted that when astroglia delivers the DHA, if you're rich in DHA, it promotes the phosphatidylserine synthesis. This promotes AKT translocation, and then a decrease inhibitory against proteins here, such as caspase-3, against cell death. So an example where that sitting on that cell membrane and having that DHA source that could effectively impact the way we're signaling proteins for brain cell health. What was very interesting is, see the DPA plus? In states of fatty acid deprivation, your DHA is largely replaced by this molecule called DPA. And in these same studies, when they replaced this with DPA, they found that this whole translocation and the inhibition of caspase and protecting from cell death was lost. So again, a deprivation example that's not unlike what we see in our preterm infants. Other proteins of importance, neuroprotectin D1, which is actually internally metabolized from the fatty acid pathways, and then brain-derived neurotrophic factor, which comes off or is largely a result of the MAP kinase pathway. So those are two pathways that are also protective, that are mediated somewhat, in part. There's probably multiple mediators, but DHA is one of those for these proteins. Well, definitely for NPD1, but one of them for BDNF. Why I brought up BDNF and why that continued to be accruing evidence for me in the importance of these pathways and what we saw nutritionally early on is BDNF is important in, in AKT activation, which then goes on to promote the CREB and the mTOR pathway. Both of these pathways regulating gene expression for proteins involved, growth, survival, neuroprotecting, etc., for CREB and mTOR, regulating protein translation of these synaptic proteins and other proteins that are important in brain health. So it's a cascade of events that occur where DHA is playing a very important story in that cascade. So what do we know about BDNF just in general and preterm? So similar to what I showed you with the full terms in the fatty acid, this study looked at a series of babies, preterm versus full term, looking at their total serum BDNF levels. And they are lower than what we see in a term infant. So if they have lower BDNF to start with, and then one of the major substrates for BDNF production is rapidly lost early, what does that do to ongoing organ development? Here's an example linking those two things, linking the diet with BDNF production or protein production. Here is a rat model where they deprived them of fatty acids or omega-3s for about 15 weeks, or a long duration. Then they took the frontal cortex and measured by ELISA the BDNF protein values. And they saw that if you do deprive of these fatty acids, you do start to affect the levels of BDNF. On the right, just to elucidate that mechanism for the MAP kinase playing an important role, this is cell culture where they looked at astroglia and then gave DHA. Yes, you can see the increased production of this protein. And then when they gave an inhibitor to that process, they saw it come down. So fatty acids low very early on, also BDNF. They are restricted or deprived from these fatty acid source. This is the potential literature that might then subsequently happen where you're now susceptible to cell death and you cannot protect yourself against some of those oxygen radicals and other things that are being imparted in the process during their NICU stay, which I'll show a little bit more. This is retinopathy of prematurity. Just one slide devoted to this because this will be a very long talk. And that is that you see that this is by Lois Smith. She does a lot of ROP work at Boston Children's Hospital. And she put together this schematic about what happens over time. And I think this is a good paper, or a good schematic to read about because there's different levels of what you need about different periods of time during your course, during your postnatal course, where certain vulnerabilities will override others. So what I mean by that is at birth, you have the appropriate substrates, or you should, to continue ongoing development here in the eye. After premature birth, there's no replacement of these factors. There's a complete abrupt cessation of the delivery that starts to give abnormal vessel growth. increasing metabolism, hypoxia, I would say acidosis, all the other stimuli that happens during the NICU are all now interacting with that vessel growth. But yet these balance of these factors that are important in regulating angiogenesis remain very altered or disturbed. So just to summarize the organ development part of it, the premature infant rapidly goes into fatty acid deficit. And during this time, these fatty acids do play an important role of normal organogenesis, and especially in the brain. But we are now lacking that appropriate substrate for much of our infants. And therefore, abnormal brain development, we do know, occurs in our preterm infants, and it might be in part due to these deprivations. But I think some of the reassuring signs in some of the models is that it could be possibly restored as well. So that's the challenge, is understanding how to restore it and how to deliver and provide that. So how about the second part of this talk, and that is acute and sustained injury. So this is a slide, actually, or a picture that I took from one of the Tufts Medical School magazine articles that was actually talking about a population that could not tamponade, did not know how to terminate inflammation. So instead of just resolving acute injury, it went into chronic injury, chronic inflammatory response. And they talked about nutritional factors. It could have been as if we were reading about the preterm infant. And instead, this was actually an article about the geriatric population and about physicians that were challenged in this vulnerable population and helping them terminate and start to cut off these chronic illnesses of chronic inflammation. So again, an example to me that these mechanisms are likely shared. We just need to understand what exposes those mechanisms to our specific populations. So sometimes preterm birth happens for reasons that we do see, and possibly chorioamnionitis is one of them. Plenty of studies to show that born from maternal chorioamnionitis, there's actually a pre-priming of the inflammatory response that ensues, and it doesn't stop at birth. That constant high elevated systemic inflammation actually persists. And not only does it persist, because I do believe the preterm infant doesn't know how to terminate the inflammatory response, then we do a bunch of things to them that continues to exaggerate and increase their inflammatory response. So there's no stop almost for many of these infants. And how do they learn it, or how can they stop? Again, not something that's unique to the preterm population. So for others studying other diseases of chronic unregulated inflammation, there's something called DAMPs, where it doesn't always have to be this inflammation pathogenically or from a pathogen, bacteria, whatever virus that's promoting this inflammatory cascade. What happens is after that acute injury, that cell death and the cell injury starts to make and produce products that continues this inflammatory cascade. And they're called DAMPs, or danger-associated molecular patterns. Again, they do come from our internal host-derived molecules that can come from injured and dying cells. And they, like PAMPs, can activate PRRs, the pathogen recognition receptors, and modulate toll-like receptors, which are important, and then mediating the rest of the inflammatory response. So often, and I'm sure we've all encountered that scenario, we're in the ICU, whether it's PICU, NICU, surgical, cardiac, and it looks like to you that you're in some septic shock or this chronic inflammation. You culture, you do everything possible, it's all negative, you put them on antibiotics anyway. Sometimes they get better, sometimes they don't. A lot of this might be mediated by DAMPs, and that's why it's sort of this culture-negative sepsis that we talk about. So it's not just that initial insult at birth that will go away, but rather it's an insult that may continue, that we need to assist this baby how to terminate inflammation. So a couple of studies just showing that these inflammatory cytokines and inflammatory proteins remain very elevated in our preterm infants. On the left is a study by O'Shea using what we call the LGAN cohort. Show these inflammatory proteins present at birth, you could see as far out as 2 weeks of life still being elevated. And then here you see it graphically from the NICHD cohort looking at IL-8, and you can see by day 3, for kids who go on to have cerebral palsy and those that do not, you start to see a splay and even a rise in these inflammatory cytokines. So it's a perpetual insult on the body, this inflammatory response. So does that make sense, that there's this systemic inflammation that somehow we're going to correlate to cerebral palsy or neural development? And then I think the literature continues to evolve exactly what those mechanisms are. But here is a nice study, I thought, that sort of started to begin to link that systemic bed of inflammation, circulating in the blood, actually affecting the brain. It's PET imaging using TSPO as a marker, a tracer of activated microglia. And I think 6 non-human primates where they did a baseline image, blue, injected them with LPS, and then within an hour and then 4 hours began to see all this lighting up on the PET scan, which is reflective of activated microglia. So there was a response specific to the brain cells as a result of an endotoxin introduced in the blood. And what activated and why activated microglia are important is they mediate cell death by the production of nitrites and other oxygen radicals. And that slide basically says that. And so turning to fatty acids, what do we know in its role in mitigating infection or inflammation from activated microglia? Here in culture, and I believe this is astroglia again, you have the nitrite production and increasing concentrations of DHA. And you see with increasing concentrations of DHA, you're able to dampen down the cell death, the amount of cell death. And then they took this astroglia and induced them either with LPS or interferon gamma to activate them and look at IL-6 production. And again, compared to baseline, you see that with increasing DHA, you again start to tamponade and bring down this inflammatory response in IL-6 production. What they called, you're sort of transforming the cell from an activated state to more of a permissive state. Something that might be important coming down the road in pediatric and adult ICUs of traumatic brain injury. Here is a model of brain injury by percussion. And this is looking at the hippocampus. Is that right? The hippocampus. And these are rats where they did not have the percussion injury and on a regular diet. And you can see by IHC, BD and F localization. The rats who did have the injury plus maintained on the regular diet, you see almost less intense IHC that's supposed to be picking up that protein we discussed already, BDNF. Those rats that were fed 4 weeks prior to the injury, an omega-3 rich diet, seem to ameliorate the degree of injury, at least to the degree of BDNF expression based on their diet and based on this IHC. And this is thought to also be important because of these distal decreased injuries, because of these distal expressions of these proteins, synapsin and Krebs. Finally, with this injury model here, this is more neonatal, 10-day rat pups where they ligated the right carotid artery and then exposed them to hypoxia for 15 minutes. And here they're looking at infarct volume size. This was baseline with saline. And then they IP'd injected them, with an N3 triglyceride or an N6 triglyceride. And you can see that the infarct volume with the N3, which is the DHA EPA line, but DHA effect was more profound here in this study, reduced the amount of the infarct size. So back to the retinopathy of prematurity, this as well is from Lois Smith's lab. This was, I believe, in Nature Medicine, where they took rats and they actually manipulated fatty acid delivery to the baby by changing the maternal diet. So they had some moms maintained on high N6 diets, so that's the arachidonic acid pathway, or N3 diets. And then they would take the pups, they were born, allowed them to continue to breastfeed, and then exposed them to hyperoxia between 7 and 12 days of age, then looked at their retina and evaluated them for vasoobliteration, neovascularization scores. And you can see that the pups that were born to moms rich in omega-3 seemed to be protective against the amount of angiogenesis or abnormal eye and retina development. They further did this in a FAT1 transgenic mice. We cannot go from the N3 pathway to the N6 or the N6 to N3. And that would be great. We can't direct ourselves to make more N3 when we needed it. So they took a FAT1 transgenic mice that can do that. And so just same mice, same diet, everything, did this study. And the FAT1 mice showed a picture just looking like this. So they were able to convert and change over pathways when they needed it at the time of injury and protect against this abnormal angiogenesis. So going back to the original study I started to discuss is when we saw those fatty acid levels change, we said, what did we know about the morbidities in the NICU at least that might be associated with this? And so when we looked at our infants and see which one developed chronic lung disease and which ones did not, we saw that those that did develop chronic lung disease were 2.5-fold more increase in developing, who were lower in fatty acids, 2.5-fold more increase in developing chronic lung disease, such that every mole drop from birth of DHA, they had a 2.5-fold increase. So in the lab, and some of the fun part, and as Michael said, is sort of bouncing back from the bench to the lab. So I thought, well, what can I do to move beyond, again, the association I found and start looking at possible mechanisms of action? Well, we adopted this neonatal hyperoxia lung injury model where we exposed the pups for 10 days starting at birth with increased levels of oxygen. But I couldn't really easily manipulate the fatty acids that they were receiving unless I changed the maternal diet like Lois Smith, and I haven't done that yet. But I thought, well, what if we give the distal mediators? Because our babies in the NICU, we can't change their diet necessarily. We don't feed them, which is a problem, but right now we don't feed them. So what can we provide them that might be protective and then somehow be related back to the fatty acids? Arachidonic acid makes something like lipoxin A4. That's both anti and pro-inflammatory. And DHA makes these Resolvin series, and I looked at Resolvin D. So in collaboration with another lab who provided the lipoxin, the Resolvin D, I looked at this hyperoxia lung injury model and to determine whether it would make a difference or not, if that potentially was one of their mechanisms. So on the left here, you see a nice section of a lung, nice open alveolar spaces. They're nice and small, numerous, nice thin walls between the different alveoli. On the right, pretty typical of hyperoxia injury from papers that you would see, and that is very dilated alveolar units, kind of arrested alveolar development. And then the spaces between the walls, very thickened, much more thickened than what you see over here. So what did I see? I gave the lipoxin and or Resolvin D1 or the combination at 0, 3, 6, and 9 by IP. So with the Resolvin, at first glance, I was like, wow, these spaces are still pretty big, if not maybe bigger. So maybe didn't help a whole lot. But if you look at these walls, they're actually very thin. So maybe some components were addressed by the Resolvin, but not everything. Then the lipoxin is a little bit mixed. You can see that the walls are much thinner, kind of like the Resolvin and in the normal group. But the alveoli are also a bit more numerous, but maybe not as small, but much better than we saw in either the hyperoxia or the Resolvin. Looking at the combined picture, you saw a really nice section of the lung, which seemed to really approximate what we were seeing with the normal room air sections. And we quantitated this and everything as well, and found that to be true across all of our mice, or as a group. So this was interesting because the alveologenesis, so I found that, yes, some of the inflammatory proteins were reduced both in the Resolvin and the lipoxin. So that made sense with the inflammatory component. And then with the lipoxin, seeing the improved alveologenesis, found that seemed to be because of an upregulation of the TGF protein, transforming growth factor. It was the first time that I realized, at least for fatty acids, to be ascribed a role that might be important in organogenesis. Again, a neonatal model allows you to possibly do that. And then soon after kind of reviewing this data, somebody in my own campus at the BI published a PNAS paper looking at EATS, E-E-T-S, in adult models in regeneration and repair and organogenesis. EETs are derivatives of arachidonic acid as well. So when he heard what I was seeing in my Poxin and I was seeing what he was seeing with the EATs, pretty excited that they might play an important role in repair. Intestinal inflammation. I know a lot of you may have a 1 o'clock, so we'll go through this quickly. In intestinal models of necrotizing enterocolitis, fish oil-rich diets reduced the susceptibility to necrotizing enterocolitis. And finally, this slide here is, I wanted to still include, comes from the original paper describing those drops of levels, but again, it's not all just one fatty acid. So when people tell just DHA, be a little wary. The DHA here, I already described that 2.5-fold increase, but when we looked at late onset sepsis, every mole drop in arachidonic acid was associated with a 40% increase in sepsis. So there's a balance, and all the fatty acids are important. So I showed you AA being prominent in composition of brains in preterm infants, important now in the protection of sepsis, and possibly important as an organogenesis and tissue repair molecule. So we need to think of them all together in imbalance. So our preterm infants, rapidly low with altered fatty acid profiles early on, affecting a period and prolonged during a period of organogenesis and repeated stimuli and chronic inflammation, and therefore may be one of the means and mechanisms by which they have these multi-system morbidities. So I just wanted, this will be just a couple more minutes. I'll finish off with what are the challenges we're seeing in understanding now how to replace these fatty acids. So what are we going to do about this information? Well, I am sure some of you have heard about the use or the compassionate use or research use of omegavin, which is a very fish oil, a DHA-enriched fish oil lipid emulsion. And again, I'd mentioned just be careful about everything with DHA. Pretty good evidence that it might help with PN-associated liver disease. So I think there's a role for specific fatty acids for specific conditions, but some groups, especially overseas, are now replacing that as their standard lipid emulsion as well. Well, this one study actually gave us some data on fatty acid levels, and you see in panel B that you have, you don't prevent the drop in DHA, which is interesting, but you do have higher levels of DHA in your study group versus your control group. But you have a substantial increase in EPA. I'm not sure if that's good. In that INFARCT study that I had shown, and it was the N3 triglyceride effect of DHA, they also have some data in that paper with EPA, and EPA didn't do much there. Also, I just don't know what it's going to do in a preterm with hematological issues as well. And then that's your EPA to AA. But it's this panel that keeps wanting me to take caution. As you can see that in this fish oil DHA-enriched emulsion, the study group was actually lower than the control group in arachidonic acid. So it drove it down even further. These fatty acids will compete for incorporation into membranes. They'll compete for enzyme and being the substrate for enzymes to metabolize further down the chain. I don't think simultaneously dropping your AA is a very good long-term maintenance strategy when we're considering normal organogenesis in the preterm infants during their NICU stay. Finally, I know that it's in formula. And so what do we know about the attempt? So there's been already some plausibility to the science that it's important. But what do we know about the formulas? Very mixed results, whether or not formula supplementation has done much of anything. And I argue that's for two reasons. One is by the time, at least for our preterm infants that are feeding, it's way here. It's about 14 to 17 days, the median in which they get full enteral feeds. They've already had a long period of these fatty acid deficits. So I'm not so sure it's enough to raise the needle. Also, our lab, and as well as other labs, have looked at malabsorption rates, or the actual absorption rates, doing some 3-day balance studies of what came in and what came out. And we show that formula-fed, in contrast to breastfed infants, but formula-fed infants, there it is, at both 2 and 6 weeks had decreased absorption of especially DHA, of these fatty acids. So we have to account for that fact, especially in early infancy, but giving more is also not an answer, and that I've heard sometimes in circles, well, let's just provide more. This is from House, I think it was Cincinnati back in '99, actually started to look at this concept of a relative pancreatic insufficient infant that's development and lipase deficient. So these are mouse pups, lipase deficient, provided, actually he saw the same with breast milk, but breast milk and formula, and starts to see an accumulation in these lipid droplets within the enterocytes. So giving more to compensate for the malabsorption is also probably not a great strategy. So definitely some challenges that we face. So there's a lot still left to do, but what are our target levels? I'm not sure we know exactly yet. So we must define them. What's that balance, again, between N3 and N6? N6 is not all bad. And we must consider what we're doing parenterally, especially during a time where critically ill patients are completely reliant on that versus our enteral routes, and they may be very different questions. Some of these structured lipids that can be manufactured, we have to make sure that the fatty acids of interest are in the right SN position, optimize digestion absorption. And then when we have studies, I think the studies need to tell us what these tissue and circulating tissue, especially for animal models, but what these levels that they are achieving, and publish them. I've seen several lipid emulsion studies now that are just looking at outcomes, but they tell you nothing about the systemic levels. And I think sometimes it's what the other fatty acids are doing might be in the story as well. So that's it. Thank you very much.
Thank you. Boy, what a great whirlwind tour of the fats. Questions for Cami? Yes, Paul.
So I have a question for some of these model systems where you're supplementing with various fats or
Right.
whatever, and you're getting benefits. How much of that do you think is cutting down on inflammation, and how much it might be oxidative stress-related issues? Maybe those things are linked together. And then, is there a nutritional component too? To my understanding of some of these cells, when they're stressed, for instance, they may make the mitochondria might make better use of fatty acids than they do glucose.
Right.
So can you tease those things out?
I think sometimes it's difficult. I think you're right. Like the first two outcomes that you had mentioned, depending on the a priori hypothesis of the paper, I haven't seen papers sort of look at it and tease through each of those pieces. But depending on whether you're seeing, is it an oxygen radical issue, or is it a decrease in the pro-inflammatory cytokine response in the cells? All I can say is studies have shown to be supportive of both, but whether it's doing it together, I don't know. It probably is, right? There's probably multiple things happening at the same time when you're altering these fatty acid levels. The third piece is also understand what you're asking and agree that the stress of the cell and the state of the cell might account for some changes. I would just say that I think it's reassuring, though, that providing a substrate, and I'm sure you can find other studies that you dig through the literature and iron and other immunonutrients that might share these mechanisms and show similar things. But I think the reassuring thing is you can provide a substrate that might be able to still rescue that cell even in the state, even in that stress state.
I mean, our problem in Neo, of course, is that you've got such a rapidly developing organism, and the critical periods just kind of move by. I thought your point about being out 2 weeks before you even address the issue, you've already started to miss some fairly important periods at that point.
So people look at isoprostanes, for instance, which my understanding is, reflective of some of the oxidative changes in nucleic acids. So people follow those in the relates to see what happens.
Not that I'm aware of. I haven't seen that. Interesting.
Although it would be followable, wouldn't it? I mean, because of the incorporation
could.
of red cells, one thing we were talking about before is that red cells often reflect what's being incorporated in other tissues, including brain. It would be possible to do. I think it's just expensive and tricky. Raghu.
Can you comment on the maternal DHA supplementation?
Yeah.
Can we rescue some of these?
Yeah, no, I think that's a great question. And yes, there's been some studies to suggest that if you provide, so there's two questions with maternal. One is if you provide increased DHA, like have the mom take some sort of supplement, and then that milk does reflect the difference in the change of that fatty acid that you're providing, and then giving that to the baby when they're on full enteral feeds, the preterm baby, you do start to see a reflection of that they start to increase their stores, and it's good. So that's a good strategy, except, and it is, and it should be a complementary strategy. For the extremely low birth weight infant, it might not be the only strategy, only because of that rapid decline, and it takes a while to get there. And I'm worried that might be a critical window of development. The second question that I'm not sure has been studied is, well, can you know that chronic lung disease graph where they all kind of went down, but the lower you went down, the more of a risk it was. I don't know what that threshold is, but if mom takes it prenatally, do you at least give them some reserve, some that allows that, they have that decline, but maybe not as impactful? I don't know, and I don't think anyone's looked at that just yet.
Most of the maternal DHA supplementation studies are in term pregnancies, where you're already dealing with an organism that has that full
Adipose stores.
adipose store,
Yeah.
so it's a little bit trickier to ask that question. The long-term neurodevelopmental studies on DHA supplemented moms has not been very rewarding yet, but again, that's because they went to term. In fact, beyond term, it's a good way to go a week beyond term for all of you who enjoy being pregnant longer than you want to be. Any more questions? Great. Well, thank you very much, Kenny. Great talk.
A to B to C to D to E.